Hypertension is an important source of questions and an opportunity to present clinical vignettes in both an inpatient and outpatient setting. In this section, we'll be discussing the definition of hypertension, its etiology, presentation, diagnostic tests, and treatment, as well as the management of hypertensive crisis. So why do we care about hypertension? Well, for one thing, it's called the silent killer for a reason. It's the most common disease in the United States, and it's the most common risk factor for the most common cause of death, myocardial infarction. When we're defining hypertension, the definition in regard to systolic blood pressure is any reading that's above 140 millimeters of mercury. The definition with regard to diastolic pressure is any reading that's greater than 90 millimeters of mercury. Now, can you think of a special population in whom we have a lower threshold to define hypertension? It's diabetics. In patients with diabetes, we have a different definition for hypertension, and that is anything over 130 over 80. So what is the most common etiology of hypertension? The correct answer is essential hypertension, or basically, we're not exactly sure what caused it. Secondary causes of hypertension are often tested, but are very uncommon in the population. Some common secondary causes of hypertension include renal artery stenosis, glomerular nephritis, coarctation of the aorta, acromegaly, pheochromocytoma, hyperaldosteronism, and Cushing's syndrome, or any cause of hypercortisolism, including use of chronic glucocorticoids for a medical condition. Finally, congenital adrenal hyperplasia can also be a secondary cause of hypertension. Again, hypertension is known as the silent killer because often patients are totally asymptomatic and have no idea that their blood pressure is high. Often, patients won't know that they have high blood pressure unless they're routinely tested in the clinic or at a health fair, or they manifest one of the signs of end organ damage. Those include coronary artery disease, cerebrovascular disease, congestive heart failure, usually diastolic dysfunction, visual disturbances, renal insufficiency, or peripheral artery disease. If the patient has hypertension for one of the secondary causes we discussed previously, there are sometimes some additional physical exam findings. In the case of renal artery stenosis, you can often listen to a bruit if you place your stethoscope at the flank. That bruit is a continuous noise that's present both in systole and diastole. Glomerular nephritis we talked about at length earlier, and along with the hypertension, you also see hematuria, edema, and can have the other associated findings depending on the cause of the glomerular nephritis. Lastly, for coarctation of the aorta, there are also some specific physical exam findings. You may see upper extremity blood pressure greater than lower extremity blood pressure. If the hypertension is caused by acromegaly, you may see other physical exam findings or hear other complaints from the patient specific to that disease. If the acromegaly is from a pituitary tumor, they may describe the classic bitemporal hemianopsia or tunnel vision. They also might describe widening of their hands and feet or coarsening of their facial features. If the hypertension is secondary to a pheochromocytoma, often the patients will have episodic hypertension, so it's not consistently high, but during an episode, their blood pressure will be sky high, and they'll also have headaches and tachycardia. Hyperaldosteronism can cause secondary hypertension, but the patient will also have symptoms of weakness from hypokalemia and the other electrolyte imbalances that go along. Once you find that a patient is hypertensive, there are other screening tests that are good to perform in this population. What these tests all have in common is they either look for early signs of end organ damage, or they look for coexisting comorbid conditions that often go along with hypertension. The first of these prudent screening tests is an EKG. This looks for coronary damage that may have come about as the result of long-standing hypertension. The second is urinalysis. What you're looking for here particularly is proteinuria as an early sign of hypertensive nephropathy. The third is glucose measurements. As diabetes and hypertension often go hand in hand, it's important to make this diagnosis in a hypertensive patient. As we'll discuss in a later slide, it also may determine the choice of antihypertensives that you prescribe for a patient who has diabetes as well as hypertension. Finally, it's important for hypertensive patients to undergo regular cholesterol screening, as hypertension and hyperlipidemia also often go hand in hand. So now that we've diagnosed our patient with hypertension and we performed all the necessary and prudent screening exams to help maximize their health, what are we going to do to treat that high blood pressure? So I know you're going to be tempted to grab your prescription pad or look through the answer choices for a medication. The best initial therapy is actually lifestyle modifications. The lifestyle modifications that you would recommend to your patients are weight loss, which has been proven to be the most effective, sodium restriction in the diet, other dietary modifications including moderation of alcohol use, exercise, and stopping smoking if the patient is a smoker. It may not be completely intuitive, but these lifestyle modifications must be tried for 3 to 6 months before any medications are started. Now, if you've done your clinical rotations, this may be one point where real life and test life don't exactly follow the same guidelines. But for USMLE Step 2, if you're given a clinical vignette in which a patient is newly diagnosed with hypertension, if your answer choices, 5 of your answer choices are an antihypertensive medicine, and one of them says one of these lifestyle modifications, choose the lifestyle modification as the best initial therapy. Okay, so let's say we did our due diligence and we had our patient who was hypertensive do all of the good lifestyle modifications for 6 full months. They come back to the clinic and they're still hypertensive. Now it's time to reach for our prescription pads and to prescribe something for this patient. So what are we going to write for? What is the best first-line drug for all comers, just the average patient off the street? The correct answer is hydrochlorothiazide, a diuretic. It's important to note that even though sometimes in clinic we'll see patients on 4 or 5 antihypertensives, 70% of the population is going to be controlled by a single medication. 90% of the population will be controlled with only 2 medicines. So there's a special case. We will prescribe hydrochlorothiazide as single agent treatment for just any old patient with hypertension. That is, unless the initial blood pressure is greater than 160 over 100. This meets criteria for stage 2 hypertension, and in this case, we want to prescribe 2 medicines immediately. So let's go back to our patient for whom we prescribed hydrochlorothiazide. Let's say he comes back a couple months later. His blood pressure is still elevated. The hydrochlorothiazide alone didn't do the trick. So what should we do now? The answer is to add a second medication. And there are 4 classes of second-line treatment that we can choose from. Those medicines are ACE inhibitors, their cousins, angiotensin receptor blockers, beta blockers, and calcium channel blockers. Occasionally, on the USMLE Step 2 and in real life, you'll be faced with a patient whose hypertension is particularly difficult to treat. Now, for this patient, you may have recommended lifestyle changes, you may have recommended a diuretic, you may have even tried other medicines that are appropriate for their comorbid conditions. But still, the patient's hypertensive. In these cases, we often use medications that aren't often prescribed, but can be useful in patients with refractory hypertension. There are 3 main classes of medicines that aren't used very often, but can sometimes have a place in treating a patient with difficult to control hypertension. The first category are central acting alpha agonists. These are medications such as alpha-methyl-dopa and clonidine. You'll also want to remember alpha-methyl-dopa as a medication that's safe to use in pregnancy. The second class of medications that aren't used too often for hypertension are the peripheral acting alpha antagonists. These include medicines like prazosin, terazosin, and doxazosin. You may recognize these medicines as drugs that are good for the treatment of BPH. Finally, we have our last class of infrequently used antihypertensives, the direct-acting vasodilators. These are medicines such as hydralazine and minoxidil. So, we talked about the use of hydrochlorothiazide as the best initial treatment for hypertension in a random person off the street. We talked about beta blockers, calcium channel blockers, ACE inhibitors, and ARBs as the best second-line treatments. And then we just talked on the last slide about the last-line, last resort medications for refractory hypertension. So all those things are true for a patient with no other medical problems. If the patient does have other medical problems, other diagnoses, you may want to start with a different medication instead of hydrochlorothiazide right off the bat. So, if you see something like coronary artery disease in the history of a patient, the best initial therapy isn't going to be a thiazide, but will be a beta blocker, ACE inhibitor, or angiotensin receptor blocker, because these have all been shown to decrease mortality and to decrease hospitalizations in patients with coronary artery disease. Likewise, if you have a diabetic patient in whom you want to prescribe an antihypertensive, you wouldn't want to start with a thiazide. You would want to start with an ACE inhibitor or an angiotensin receptor blocker. Why is that? Because both of these medications have been shown to reduce or slow down protein loss by the kidney and prevent the progression of diabetic nephropathy. If a patient has hypertension but also has benign prosthetic hypertrophy, again, you wouldn't want to start right away on a thiazide. Instead, you would use an alpha blocker. Why is that? Because it's going to do double duty for you. It's going to help control the hypertension, and it's going to reduce the obstructive urinary symptoms the patient's experiencing. If the patient has hypertension and also suffers from depression or asthma, you definitely don't want to use a beta blocker. This is because beta blockers can act on the beta receptors in the lungs and worsen bronchospasm in patients with asthma. Beta blockers have also been shown to worsen depression, so you want to stay away from those if a patient has that coexisting diagnosis. In patients with hyperthyroidism, you want to use a beta blocker first. That's because beta blockers can act on the beta receptors in the heart and reverse or prevent some of the effects of excess thyroid hormone on the heart. In a patient with osteoporosis and hypertension, you're going to want to use a thiazide. That's because of its effect on calcium. We've spoken a lot about hypertension so far. Remember that the definition for hypertension is any blood pressure reading over 140/90. Unless your patient is a diabetic, in which case we have a lower threshold of 130/80. Next, we'll discuss a more severe form of hypertension, known as hypertensive crisis. You may have heard or read about terms such as hypertensive urgency or hypertensive emergency that have a cutoff blood pressure of anything over 180/120. But for the purposes of the USMLE Step 2, hypertensive crisis is any degree of hypertension that's accompanied by symptoms of end organ damage. These symptoms occur when the blood vessels that lead to an organ are affected by the high blood pressure. The 4 symptoms that you'll want to look out for in clinical vignettes on the USMLE Step 2 are confusion or altered mental status, blurry vision or other visual changes, dyspnea or shortness of breath, indicating that the pulmonary vessels are being affected, or chest pain. You may remember from cardiology that the rate pressure product is the systolic blood pressure times the heart rate. And the rate pressure product is a good indicator for how much oxygen the myocardial muscle is using. So anytime somebody is in a hypertensive crisis, their blood pressure is high and their heart is requiring more oxygen. If their heart is requiring more oxygen than the coronary vessels can deliver, that leads to angina, ischemia, and chest pain. So back to the question that the USMLE Step 2 loves to ask. What is the best initial therapy? The correct answer? Well, there are two. First-line treatments for hypertensive crisis are either labetalol or nitroprusside. What do you do if both of these are an answer choice? Well, if I had to choose between one or the other, I'd choose labetalol. And that's because nitroprusside requires very intensive monitoring while it's being given. Typically, it requires that the patient has an arterial line and the blood pressure is monitored very closely minute by minute. Now, what if the symptoms are more mild? Second-line agents can be used in cases like this and include enalapril, calcium channel blockers like diltiazem or verapamil, or esmolol. The one thing to remember about esmolol is it has a very short half-life of only about 9 minutes. So its effects, although they'll start very quickly, aren't going to last very long. And with that, that concludes our discussion of hypertension.